Alrighty, we'll get started. Hello, everyone. Good morning. It is my pleasure to introduce Dr. Daniel DeLuca, Assistant Professor of Neurology here at WashU in St. Louis. Dr. DeLuca completed his neurology residency at the University of Miami-Jackson Memorial Hospital, where he also served as chief resident before pursuing a fellowship in movement disorders and a master's in clinical epidemiology and healthcare research at the University of Toronto. Here at WashU, he specializes in the care of patients with a wide range of movement disorders and has been recognized for his dedication to education, receiving the Sven Eliasson Award for Teaching Excellence in 2023-24, among many other teaching awards. His research interests focus on neuromodulation, epidemiology, and novel therapies for motor and non-motor symptoms associated with movement disorders, for which he is sharing his expertise today. Please join me in welcoming Dr. DeLuca to the podium. Thank you so much. Excited.
Okay, thank you so much for the very kind introduction. It's my pleasure to be talking to you about neuromodulation in movement disorders today. And that's a topic that Dr. Jean-Moon Lee asked me to talk about, just so we can increase awareness and also show you how much we can do for our patients with movement disorders. I know it's an internal medicine audience, but I think you guys see a lot of our patients for the first time, especially essential tremor. These patients often stay with internal medicine for a long time. Therefore, the importance of knowing about these therapies that I think are going to change your perception about what we can do in neurology, hopefully. Okay, so I have no disclosures for this talk. And again, I'm going to try to give a broad overview of what is neuromodulation for movement disorders, but as a whole for neurology and how much you can help our patients and when you should refer patients to us. Here I have two videos. The first one is a patient with essential tremor, and you might see that she has a bilateral postural and kinetic tremor of her hands, and that's the classic patient that all of you would probably be seeing in your own clinic. Maybe you might also see the second patient here, a patient with a rest tremor who also has hypomimia, so lack of facial expression, and the slowness of movement, and that's a patient with Parkinson's disease. This is the bread and butter of movement disorders, and to some degree, all of you see patients with essential tremor and Parkinson's disease in your clinic. Years ago, we would say that we have a few medications that we can try for these patients, propranolol, primidone, levodopa. And the classic understanding of neurology was a diagnose and adios, right? It would just say, okay, you have Parkinson's disease, great, levodopa is not helping you, that's perfect, let's increase. And that's how I thought neurology was in medical school too. I said, no, there's not much more to do, it's just medication, if it doesn't work, that's fine. My goal is to change this perception today. I'm going to show you that we can do more than just give medication or just say, that's what you have, let's move to the next patient. So I'm going to start with a very brief introduction about Parkinson's disease and essential tremor, just what I think internists should know. Parkinson's disease is now the second most common neurodegenerative disease, only after Alzheimer's disease, and is the fast progressing, and is actually the fastest progressing neurodegenerative disease in movement disorders or in neurology as a general. And the prevalence of Parkinson's disease is increasing year by year. As you can see here, Missouri has a high prevalence of Parkinson's disease. We don't know exactly why. There have been many theories about exposure to pesticides, including in the rural community, but we still don't know exactly why patients have Parkinson's disease, likely a combination of genetic factors and environmental factors. I tell my patients it's almost like lung cancer, right? And you guys know much more than I do. It's the exposure to smoking, but at the same time, some people smoke and don't have lung cancer. What is different there? And it's the same with Parkinson's disease. We have the pure genetic form of Parkinson's disease, but most patients probably have some specific variants that when exposed to some environmental toxins, they might increase their risk of Parkinson's disease. Here's the classic example, someone with rest tremor lack of facial expression, and also with rigidity and bradykinesia. And the treatment for Parkinson's disease, as most of you know, is increasing the levels of dopamine in the brain. And we do that by giving the precursor of dopamine, levodopa. It can cross the blood-brain barrier, but we have many other options of medications that we don't usually prefer, but we can give dopamine agonists, we can give medications to extend the duration of the levodopa, or to make it work for a little longer or prolonged period of time. Now, the main issue is that patients respond quite well to the medication at the beginning of the disease, but then later on they develop these fluctuations and dyskinesias, or the medications don't work as well. We almost say it's like a roller coaster. They take the medication, it kicks in, and then it wears off. Or maybe the medication doesn't help them completely, and that's when we have to think about the advanced therapies. And classically, we know Parkinson's disease as this figure here, as the older patient using a walker, having trouble with fine motor activities, but we know that Parkinson's disease is much more than that. Every day in clinic, we see patients like this one here, a young patient who might have just a little bit of symptoms, but soon this patient who is still working might have some debilitating symptoms, and then they have to stop working, and that's the kind of patient that we have to also try to help early in the disease course. And I can switch gears to essential tremor now, and just tell you a little bit more about essential tremor, which probably you also know a lot about. It's the most common movement disorder, actually. The prevalence is about 5 per 100,000 patients. And here's the classic examination of essential tremor. It's someone with a postural and kinetic tremor. So when they're trying to draw this Archimedes spiral, for example, they have a lot of tremor. And before it was called benign essential tremor, which we don't call this anymore because we know it's not benign. We know that it can be very debilitating. I have seen patients who are surgeons and they have trouble doing fine motor movements. I have seen patients who are cinematographers and they cannot hold the camera, so they cannot work anymore. And despite being on medications, these patients still cannot function. And especially essential tremor, we have patients in their 20s, 30s, sometimes 50s, patients that are still working, that still want to get promoted, they still want to go on to do more things, and sometimes they cannot because of their essential tremor. In med school, I had a friend who had severe essential tremor who wanted to become a surgeon, but he gave up because he had essential tremor and he couldn't do fine motor movements. So it's a common disease, common in the young population, and I'm pretty sure some of you see these patients in your own clinic. They often just come to us after decades of symptoms once it is very debilitating, and when the internists say there's nothing else to be done. As you know, essential tremor, we have 4 medications roughly. Propranolol and primidone are the first line therapies, and then we have topiramate and gabapentin as second line. The efficacy of these drugs is not as high as we would like to. Many of these patients do not respond well. They have side effects. They have bradycardia. Many of these patients are on anticoagulation, so we cannot prescribe primidone. It becomes challenging to sometimes take these medications for essential tremor. And again, the efficacy is very limited. And now I start talking about neuromodulation. And what we mean by neuromodulation is altering the electrical activity of the brain to some degree by either electrical impulses, chemical impulses, or any other side of therapy that can modulate the brain network. One of my patients told me one day, and I really liked, she said, "You're calibrating my brain." And that's kind of what we're doing. We're calibrating the brain in some sense to try to help with the symptoms. Many people consider movement disorders as a disorder of the oscillation of the brain. So another way of thinking about it is an orchestra that is not synchronized. It's almost like they're not playing at the same rhythm. And what we're doing with neuromodulation is sort of getting a new maestro to make everyone synchronized again. And that's what I tell my patients in terms of calibrating the brain or modulating the brain. We have different types of therapy. We have deep brain stimulation, TMS, vagus nerve stimulation. But I'm going to focus predominantly on deep brain stimulation and MRI-guided focused ultrasound. Deep brain stimulation is almost like a brain pacemaker, and that's how I explain it to patients. You have a battery that goes all the way up to your brain, and that can change the brain network. It is used for patients that fail optimal medical therapy, or those patients with Parkinson's or essential tremor that have refractory tremor. As I mentioned before, these patients can have ups and downs, and that's also when we start considering surgery for Parkinson's disease and essential tremor. We have different targets in the brain. For Parkinson's disease, it is predominantly the subthalamic nucleus and the globus pallidus, and for essential tremor is the thalamus. And this is usually how the surgery is done. Here, what should we do is smaller holes, not as big as this one, but that's a video showing the burr holes and then inserting the electrodes in the brain. And these electrodes are going to deliver electrical activity to stimulate or calibrate some of the brain networks. The way what we have learned so far is that it's probably more of an inhibitory pathway. So we're kind of blocking the impulses, almost like there is an abnormal pathway carrying the tremor and some of the symptoms, and we're blocking. But we also know that it can excite some other fibers, and that's why we call modulating, because we're exciting and inhibiting. And you put this battery that goes all the way up to the brain to deliver the electrical activity to this electrode. We now know that deep brain stimulation has a great efficacy for Parkinson's disease. That's one of the pivotal studies published in the New England Journal of Medicine in 2006, showing that deep brain stimulation can improve quality of life in Parkinson's disease, and that's this score here. It can also improve mobility, bodily discomfort, cognition, and all of those things. And that's also from this study showing that comparing patients with DBS versus optimal medical therapy. And what they're trying to show here is that they have more of on time, meaning when the medication is working and they feel well, and they have less dyskinesias, which are the involuntary movements, sort of similar to Michael J. Fox when he's speaking. That's what we call dyskinesias. So deep brain stimulation was shown to significantly improve motor and non-motor symptoms with this study. And later on, we kept having many other clinical trials that supported this study. This is a long-term effect of deep brain stimulation. About 15 years later, still showing some benefit of DBS with less dyskinesia, less off-state, less drugs in general, and improved quality of life. So really supporting the role of neuromodulation for Parkinson's disease. In movement disorders, we say that one video is worth 1,000 papers, probably. So I wanted to introduce you to one of the patients that I was able to take care when I was in Toronto. This is Harry. He was a host for a very famous Canadian channel there in Toronto, in New Brunswick. And he later on had deep brain stimulation, and he decided to go public about his story, and he did a piece about his experience with DBS, which I'm going to play for you now.
It shows the difference of having the device turned on versus when it's turned off. When you get deep brain stimulation, they give you these two things: basic cell phone with the program on it, and this is a data collector. And if I want to turn off my therapy to illustrate what I would look like with full-blown Parkinson's and no relief from it, I would turn my therapy off. And this is going to prompt me to use this to be sure I'm doing what I want done. So place communicator and continue. I'll do that. So this is downloading information from a pack in my chest that is very much like a pacemaker. Very small, and in some cases it has a rechargeable battery. Now I can feel my DBS, my deep brain stimulation therapy, going off, and the reaction is almost immediate in that I begin to shake and sorry. And that's what it's like with the therapy off. So if I didn't have deep brain stimulation, I would have to take drugs to control this. I've been able to minimize my drug intake because of deep brain stimulation, which is good because most of the drugs have some side effects. But as you can see, if I wasn't taking medication and not taking deep brain stimulation, I would have a very hard time even taking a drink of water. And for people who have Parkinson's, it's not really a pleasant way to live. However, we do have deep brain stimulation. In my case, it works pretty well. I'm going to turn it back on. And it's communicating with this device that will now tell the pack to start. And I can feel a tingle in my heel. It creeps up my leg as the stimulation starts to take place. So those electrical impulses now are back. They're firing again in my brain as they do night and day, and overriding that impulse I have to shake or tremor. And as you can see, the results are almost instantaneous. Turns out I'm one of the lucky few.
Yeah, so you can see how this is a pretty dramatic improvement, and how for someone like Harry, who was a host of the 8 p.m. news channel, he couldn't work anymore with the Parkinson's disease symptoms, and after getting DBS, he was able to go back to work and do his job and spend time with his family and do the things that he liked to do. Now, obviously, it's not all perfect. I have to tell you about some of adverse events. It's not very common, but it's a brain surgery, so you can have a bleed, you can have a stroke. It's roughly around 3% of all patients that are going to experience a very significant side effect or complication. I think the numbers now are much lower at WashU. It's a little less than 1% of the patients that experience brain bleed or pneumoencephalus or air inside the brain. So not very common, but still a potential complication. Now, we can switch gears to essential tremor. And as I mentioned, is the most common movement disorders. All of you probably see this. And we insert the electrode instead of the subthalamic nucleus or GPI, like in Parkinson's, in the VIM nucleus of the thalamus. And it's also proven to be effective in controlling the tremor. And I can show you a video of the operating room, and that's me on the right, that's Dr. Willie on the left. So the patient has to be awake. So we can insert the electrode and test. So you can see that they have a very significant tremor. And as soon as we insert the electrode, there is a disruption of these pathways even before we turn the DBS on. And you can see how it immediately improves the tremor. And then we get a tablet and we turn it on and we test each specific contact. And again, it's something that we do once or twice a week here at WashU, sometimes 3 times a week. And no matter how long we have been doing this for, we still feel very impressed about the dramatic improvement. Some patients cry in the operating room because they're awake and they have this tremor for decades, and suddenly the tremor is gone. So really an impactful procedure. And this is one of the other patients telling her story of how much it helped her. She was a hairdresser too, so she couldn't work anymore, so she got DBS for essential tremor.
I can do a lot more with it than I could before. I couldn't eat. I couldn't drink out of a glass. Now I can, and it's improved immensely.
And her DBS is on. And then if we turn the DBS off, it's almost immediate that she, again, has the worsening tremor, almost like she never had the surgery done. And that's something that we do in clinic routinely, just to check the electrodes, see if they're working well, and you can see how debilitating this would be for her. Now, where do we go from now for deep brain stimulation? We have new targets that we can insert the electrodes, alternative stimulation parameters. So for example, in this study, we have found a small spot of one of the nucleus to specifically reduce medication for patients with Parkinson's disease, and we can try to sort of find these networks that have specific benefits or side effects and go very closely to where they are to help us with specific symptoms. We also have what we call steering, meaning this structure here is the thalamus, the blue one, and the yellow one is the corticospinal tract. So when we're trying to stimulate, we ideally just want to get the thalamus and not the corticospinal tract. If you remember, the corticospinal tract would cause muscle contraction. So these patients could actually feel that the muscle is contracting, or they have slurred speech, dysarthria. So in a way, we want to get away from the internal capsule, for example, or some other important structures. And with some of the current electrodes, we can't because they give you a full energy all over the place. But now they have these new electrodes that we call steering electrodes that you can steer the electrical activity to wherever you want it to. So you can have a much more precise stimulation of the thalamus and avoiding the corticospinal tract, for example. But this can be done in many other structures. You have to avoid, for example, some structures that can cause more depression or more anxiety or more cognitive side effects. And this is what we can do in a more precise, individualized approach. We also have something that we call adaptive deep brain stimulation, which basically receives information from the brain, some of the brain waves or neurophysiology of the brain, and it basically corrects the programmer so it goes faster or slower depending on what the patient is doing. So here someone is chopping vegetables and it's going to send this information to the electrode, then to the battery, and that's going to change the amount of stimulation. So I tell patients it's almost like a driverless car that if you're going too slow, it's going to push the gas pedal. If it's going too fast, it's going to push the brake. That's sort of the idea. And we expect this to improve over time as well in a way that it only starts delivering electricity when you need it and only to the specific parts of the brain that you need it. Now I'm going to talk about MRI-guided focused ultrasound, which is a much newer procedure that we have been doing in movement disorders, but also at WashU. It has been going on for actually almost 100 years when they first did an ablation of the brain. And they actually had this a clinical practice in the 90s for brain tumors. And they did consider the possibility of using it for movement disorders, but then DBS or deep brain stimulation started, so they forgot about the focused ultrasound in a way until they revisited the possibility of this focused ultrasound. And in 2008 in Switzerland, it was done the first procedure, and then in 2011 at Virginia, and that's when it was approved in around 2016. It is a novel, minimally invasive ablative procedure that uses thermoablation, so basically increasing the temperature to burn a part of the brain, really. It was approved in 2016 for essential tremor, in 2018 and 2021 for Parkinson's disease. It is almost like a cardiac ablation in a way, but it's for the brain. It uses a different technology, of course. This one is using the ultrasound beams to increase the temperature in the brain, and once it reaches the temperature desired, it burns that part of the brain really, and you are blocking these abnormal pathways. And that's what we can see here, that in fact the patient has to shave their head completely, and they get inside an MRI machine, you do the ablation, and they go home the same day, sometimes without the tremor, and that's it. And they don't have a hardware, they don't have anything else. This is how the procedure works. It's really like an MRI. The patient is awake. This is not here. This is in a hospital in Canada, and you can see how they're burning a part of the brain, either the neurosurgeon, the neurologist, or the radiologists, and you keep testing the patient at the same time. So you ask them to write or to pretend they're drinking a cup of water to see if the ablation was successful. So we're testing the patient, seeing how they're doing after this ablation. And we can have side effects as well. There is usually a normal swelling of the brain, and that can cause some slurred speech, dysarthria, or rarely it can cause also weakness. Most commonly and the most concerning side effect would be gait imbalance. And that can happen in up to 30% of patients, and I'm going to discuss this a little further, but weakness, which is the concerning side effect, almost like mimicking a stroke, is rare, less than 1% of patients. In this study here, they looked at the side effects of MRI-guided focused ultrasound, and 45% had gait decline that remained persistent in about 30% of patients. So it's one of the concerning side effects that if someone has additional neuropathy, or if they are older patients already with some gait imbalance, we try to stay away from this procedure, or we have some reservations about doing it. Here's the long-term outcome of MRI-guided focused ultrasound. It's still persistent, but you can see that after a few years, maybe there is a recurrence of the tremor at a mild level, but still it's a very effective procedure in treating essential tremor. It has also been approved for Parkinson's disease, but it's a little more complicated. In Parkinson's disease, we know that patients not only have tremor, they have these ups and downs, they have cognitive side effects, non-motor symptoms, and focused ultrasound is not going to be able to treat that. The focused ultrasound is just treating the tremor. So it's a little more complex, and I think all of us agree that focused ultrasound is a good therapy for essential tremor, but for Parkinson's disease is a little more complicated, and I think we still prefer deep brain stimulation in most of the cases. However, if they have a predominantly unilateral disease, focused ultrasound might be an option. And here's the first study that approved focused ultrasound for tremor-predominant Parkinson's disease, published in JAMA Neurology, and then later on in the New England, they had a subsequent study in 2023 approving focused ultrasound for Parkinson's disease motor fluctuations, these ups and downs. And you see here the side effects are relatively minimal in about 1% of patients with slurred speech and weakness. And that's the video of one of the studies showing that this patient has a unilateral tremor involving his left arm and leg. And after the ablation, you can see the improvement in his tremor. And this is in keeping with the rest of the literature and the study showing a benefit in terms of tremor, ups and downs, and reduction of medication. And this is after the ablation, and you can see how there is an improvement of the tremor as well. Again, it's a progressive disorder, so it's difficult to imagine that a single ablation would help them for decades to come. It's usually something that helps them at that point of time, but then as the Parkinson's disease progresses, they probably would lose benefit. So a little more complex for essential tremor. The limitations of focused ultrasound is the cost, is the fact that we can only do in certain brain regions, and that it's not for everyone. We should check the skull density ratio, and depending on the thickness of the skull, you might not be able to perform this procedure. You have to shave the head completely. So for some patients, you just say that and they give up the procedure already. They don't want to shave their head. And there is also the side effect profile, especially the gait imbalance. And just as a comparison, deep brain stimulation has been approved for about 30 years now, while focused ultrasound has been approved just recently. The focused ultrasound is an ablation, so it's irreversible, while deep brain stimulation, we can still do some fine adjustments over time. However, we need general anesthesia for deep brain stimulation at some point so we can install the pacemaker, while MRI-guided focused ultrasound is almost like an outpatient procedure. They come here one morning, they go home the same day with an improvement of their symptoms. For MRI-guided focused ultrasound, there is no opening of the skull itself, while for DBS you do, and you're going to have a hardware for life with deep brain stimulation and not for focused ultrasound. And here's sort of how we do it at WashU. These patients come. For the focused ultrasound, they stay in the hospital for less than a day. So they come at 6 a.m., they leave around noon or 1 p.m. And we see them every 3 to 6 months. And it's also a fantastic treatment with an immediate benefit that doesn't require general anesthesia, incision, or anything like that. Here's someone, I think that was maybe at 9 a.m. and that's at 9:10 a.m. You can see how in a matter of minutes, the amount of tremor benefit is just incredible. Without any incision, without any general anesthesia, just inside an MRI machine with ablation. And here's one of our patients that we have recently published that had this rare genetic syndrome resembling essential tremor. It's called Fragile X tremor ataxia syndrome. We just treated his right hand, and that's why he still has the left hand tremor. Before it was bilateral, and it looked the same in both hands, so you can see how much benefit he had from the procedure. And here his tremor scores as well, and you can see how a reduction of his tremor scores over time, and how before surgery he couldn't write, and then after surgery he was able to perform better movements, especially handwriting. And his balance was still okay. He might have had a little bit of worsening gaining balance after the procedure, but to the point that he was very happy about it. His main goal, he's 85, and his main goal was to be able to eat on his own because he needed help to eat. He had to ask his wife to feed himself, so he feels very happy that he has the autonomy to eat by himself, for example. And he didn't want to come here for hardware adjustments and come back and forth. He just wanted to get a one-time procedure and go home. Now, we do have other applications of focused ultrasound, and we're kind of getting into the future of neuromodulation for movement disorders here. We can have something called low-intensity focused ultrasound. So some medications that we give do not cross the blood-brain barrier because they're too large molecules. So we can use low-intensity focused ultrasound to open the blood-brain barrier for a brief period of time. So these medications can cross the blood-brain barrier and go where they're supposed to go in the brain. So for example, you can do this for Parkinson's disease. You can give a medication, which is now experimental, that cannot cross the blood-brain barrier, and you put the low-intensity focused ultrasound exactly in the globus pallidus, for example, for a few hours, and that briefly opens the blood-brain barrier, and the medication is able to reach the target. But the application for this is really broad. You can do this for brain tumors, for example. You can put the low-intensity focused ultrasound to open the blood-brain barrier and simply deliver the medication to that specific part of the brain. This has been done also for many other neurological conditions. For example, they have used this opening of the blood-brain barrier for Alzheimer's disease, for ALS. They have used this focused ultrasound thalamotomy for chronic pain, even for modulation of the visual cortex, for brain tumors, as I mentioned, and for psychiatric disorders, including depression and OCD. And I also wanted to show some, I'm just going to pause here. This is also future indications of focused ultrasound. On the left, we have someone with what we call musician's dystonia. So it's a type of involuntary movement that affects musicians predominantly, that when they cannot play or perform a movement because of the underlying dystonia. And they had focused ultrasound done, so you can see how that's before. You can see how focused ultrasound helped. That's someone who had a primary writing tremor or dystonia. It's a Japanese patient, so it's not our alphabet. And he had dystonia only when writing, and that's at baseline. And then after the focused ultrasound, they were also able to improve their handwriting. And I have talked about neuromodulation for essential tremor and for Parkinson's disease because those are the most common movement disorders and probably the most relevant for this audience. But the future of neuromodulation is in many other movement disorders, neurological disorders, and beyond that. In medicine, it's something that can be used as well. For example, we now have tibial nerve stimulators for incontinence. We have peroneal nerve stimulators for foot drop, spinal cord implants for chronic pain. And in fact, a lot of the technology for movement disorders came from the spinal cord stimulators. You have the hypoglossal stimulators for obstructive sleep apnea. Cardiac devices are also, to some degree, modulation. We have cochlear implants. We have deep brain stimulation as well, as we discussed, and vagal nerve stimulators that we can use for epilepsy and depression. And in fact, if we look at the future of neuromodulation, a lot of it has been in the psychiatric domain. A lot of work being done in Tourette syndrome, in OCD, as well as depression. And those are for patients that are refractory to treatment. And beyond that, if we look at the future of neuromodulation, we can see here seizures, as I mentioned before, obsessive compulsive disorder, pain, depression. But this has also been used in Alzheimer's disease, to restore function in patients after traumatic brain injuries, or even in disorders of consciousness. There has been some studies looking at neuromodulation for comatose patients and if that can restore consciousness. So really quite a lot of different applications for neuromodulation. And at the beginning of the presentation, I showed these two patients and just showing how we, decades ago, would not be able to offer them many options. We would just say diagnose and adios. You have essential tremor, you try propranolol and that's it. Or you have Parkinson's, you try levodopa. And I hope that with this presentation, we're able to get a sense of how much we can help our patients, how much we can improve their quality of life with some of the neuromodulatory techniques that we have available, and how much we have been increasing the amount of indications for these therapies. With that, I would like to thank our team, Dr. Usha is the head of neuromodulation, Dr. Norris is the head of movement disorders, and the rest of our team, and nurse practitioners that work pretty hard to be able to see our patients and to take care of them and improve their quality of life. And in conclusion, we have discussed some of the surgical therapies to enhance quality of life in essential tremor and Parkinson's disease, and we have explored some of the new indications for treatment and new strategies that can help some of our patients. And with that, we have a little more than 15 minutes for questions, if anyone has any questions. Yeah. Thank you very much.
Dr. DeLuca, thank you so much. That was a really terrific presentation. We have time for questions. Oh, I'll start. So, I do think a lot of these patients are seen in internal medicine, and historically, there may have been delayed diagnosis or prolonged time with medical therapy that wasn't working. When and how quickly should patients be referred to neurology for these therapies? And are there absolute contraindications where patients wouldn't benefit?
Yeah, no, I think probably someone that has a diagnosis of Parkinson's disease, I think they would benefit from seeing a movement disorders at some point. I think we have now a lot of therapies, a lot of even clinical trials that can help these patients. So I think early on, someone with Parkinson's disease should be seen at least once by a movement disorders neurologist. Even very early on is a good idea. And essential tremor, because it's such a common condition, if they're responding well to medication and if they don't have any specific contraindications to treatment and they feel very satisfied, I think internists can keep seeing them. But if they have disability related to their tremors, or if they still have issues related to medication side effects or contraindication, I think that's when they should be seeing a movement disorders neurologist, because that's when we can discuss the surgical therapies, focus ultrasound, and many other options, including clinical trials as well. Yeah.
Griff? Bowen, Dr. Bowen?
It may be anecdotal, but for years I've told patients that have essential tremor, alcohol use slows it down a little bit or modulates it. Is there any truth to that?
Yeah, absolutely, yeah.
Can you repeat the question?
So the question was if patients with essential tremor improve with alcohol, and they do. It's a very common fact, and we use this in our history to confirm that they have essential tremor. If the tremor responds to alcohol, it usually supports a diagnosis of essential tremor. We have to be careful. I think old school neurologists, some of my mentors, they used to have a bottle of whiskey in their clinic room, and they would actually ask patients to drink and see how much benefit they would have from tremor. I don't think I can do this now. I think I would go to jail. But they, it's actually very common, and we have to be careful because many of these patients use alcohol as a treatment, and it's not uncommon for us to see high levels of substance abuse, including alcohol abuse in our patients, and that's a contraindication for surgery. If they have alcohol abuse and if they have uncontrolled psychiatric conditions, we cannot do the surgery. But very, very common fact. If we have questions about Parkinson's disease, essential tremor, because it can overlap, certainly having this history helps us narrow the diagnosis.
Stan, Dr. Meiser?
To some extent, it would seem that the tremor that one sees here is something like the past pointing and decomposition improvement that you see with cerebellar injury. And we know that with cerebellar injury, the major issue is going to be an inability to have inhibitory output from Purkinje cells. Is there a key cell in this system that works in an analogous fashion?
So that's a great question, and I think you asked about the cerebellar pathways or cerebellar contribution to the tremor, mostly for people at Zoom. But essential tremor, we know there is a cerebellar component. The theory is that it is perhaps localized in the cerebellum. Maybe it's an abnormal pathway, the cerebello-thalamic cortical pathway. So it's like this pathway from the thalamus, cerebellum, and cortex. And the idea of the DBS is that you're acting in a part of this pathway, which is in the thalamus, but we do not think it originates from the thalamus. We think it is just passing through the thalamus from the cerebellum to the cortex. They have tried to do cerebellar DBS, and in fact, not for tremor, for some other indications, maybe out there for tremor somewhere, but not very commonly. It's just not very clear that it helps as much. It sounds like even though there is a cerebellar component acting along the pathway, like in the thalamus, works best, and we don't know for sure why, but that's where the research is probably moving forward, is to try to understand, is there a different target in the cerebellum that we can act on and things like that. But some of the new drugs as well, as you mentioned, they are acting in some of these channels predominantly in the cerebellum, so it's a very good observation. Yeah.
And one more thing, might you tell us something about the actual stimulation paradigm? Is it single stimuli, is it trains of stimuli, is it trains interrupted by pauses, and you have to tune those sorts of variables?
Yeah, and the question was, what kind of stimulation are we using here? Is it a single one, a dual? We have all of it. We basically got the technology from the spinal cord stimulators, so even the parameters that we initially used came from the spinal cord stimulators. And we had a limit of frequency that we could use, but when we are doing the stimulation, we have some parameters that we can change, including pulse width, the frequency, and the amplitude of the stimulation. So we usually start with 90 hertz or 180 hertz, and that's how fast it keeps releasing this energy. But if we have side effects, sometimes we can do dual stimulation. We stop the stimulation and then give on the other side, and we keep doing this interleaving stimulation that we call. Depending on side effects, we can also do a continuous and low stimulation all the time with a higher pulse width. So really, a lot of different types of stimulation, which makes it very complicated for us as the clinicians to adjust that, because it is not a simple algorithm that we can follow. It is, we have endless possibilities to do this stimulation.
So you tweak until the tremor stops.
Yeah, we have some general idea of how we can do this adjustment or of the energy. We start with a specific general consensus, and then depending on benefit and side effect, we can change this. And that's why they have to come to our clinic every 3 to 6 months to make these small adjustments of the stimulation. Yeah.
So historically, you know, it was hard to get patients into neurology because of the national shortage of neurologists and even some of the shortage of neurologists here and the increase in prevalence of these diseases. Can you tell people a little bit about how you all are working to improve access and what the current wait times are to get patients in for movement disorders?
No, you're absolutely right. We have a very long wait list, and that's the main challenge in seeing some of these patients. And the main strategy that we have found was creating specific slots to these patients. So even though our wait list might be longer than a year sometimes, we block our schedules to be able to see patients for what we call advanced therapies or neuromodulation therapies, so we can see them even in 2 months or 3 months. It's just important that if you are suspecting this patient might benefit from DBS or focused ultrasound, you should make it clear to us that this is a referral for advanced therapies or neuromodulation or DBS, so we can get them quick. Because if they wait 1 to 2 years to see us, then it might be too late, or we have not really helped them for these 2 years when we could be doing a lot for them. So, yeah.
That's great. Thank you so much. Any other questions?
I thought I heard earlier in the presentation you mentioned that DBS for Parkinson's can have benefits for cognition. Is that the case? I thought I heard before that they can actually have deleterious effects on cognition.
Yeah. So classically, so the question was about cognition and DBS. You're right. If you do bilateral ST and DBS, you can have potentially worse cognitive effects, and that's why we do a neuropsychological evaluation before surgery to see if they have any cognitive issues. Because if they have dementia, for example, that's going to get worse. Or if they have mild cognitive impairment, it might worsen some of the symptoms. But they have been doing specific types of DBS. GPI might not necessarily cause so much cognitive impairment, but they have been trying to stimulate other parts of the brain as well, like nucleus accumbens or other specific areas to improve cognition in Parkinson's disease. And sometimes we can also see worse cognition more related to apathy and lack of dopaminergic input in a way. So if we do DBS for some of these patients, they might benefit in terms of level of consciousness and overall cognition. But you're right, classically, cognition does get worse with DBS in some of these patients. Yeah.
Yes, hi. I'm a hospitalist and I have 3 quick questions. One is, are these DBS, is it MRI compatible? And what about for patients who also have a need for a pacemaker? Is there any interaction between those two? And a common condition I see with pacemakers is there may be a line infection where it needs to be removed. Is that also a risk that you see sometimes with DBS?
So the questions were about the technical aspects, including if it's MRI compatible, the risk of infection, and if they can have a pacemaker at the same time. Yes, most of the new devices are MRI compatible. The only thing is that the patients cannot do with this battery is skydiving and deep diving in the ocean, and our patients usually don't do this very often. But you would be surprised. Some of them do actually, and they didn't go for DBS because of that. But most of them are MRI compatible now. If they have a pacemaker, you can put it on the other side. They usually just need one battery. Or we have seen patients even putting on the back if they have 2 devices here. The same with patients with breast cancer that had radiation, for example. It might be difficult to place the pacemaker, so you can find a different part of the body, and it doesn't matter where. It can be on the abdomen, the back. You can find different parts. And risk of infection, it is very uncommon now, but it can happen. I think I have seen just 1 case of infection in the past few years doing this, and with the kind of care that they receive now, it's very uncommon for patients to have line infection related to DBS. Yeah.
Just logistically, with insurance coverage, is it covered? And say they're waiting to get in, what are some steps that the internist can do prior to kind of have them teed up for evaluation?
Yeah, the question is about insurance, and if the internist can help us in any way. Insurance covers both procedures, and again, we have a lot of evidence to suggest that it helps. I have never received a denial from our team and any insurance at all. We have specific ways of doing it. We have a team from neurology and neurosurgery that can get this approval done quite quickly, and we have to show specific eligibility from the patient and the memory tests and all of those things. But it's usually very straightforward. It's not very expensive for the patients. It's usually all covered by insurance nowadays. Yeah.
And things that the internist can do to tee the patient up to make your job easier?
Yeah. I think for essential tremor, you can certainly try one of the initial medications, and might be a good idea to tell us, he's not eligible to try this medication because of maybe he has AFib and he's on anticoagulation, or I often talk to some of you about, can I stop propranolol and try this one? Can I increase the dose of propranolol? So I think just having this open communication is very helpful for us, so we can decide together how to best manage the medications. You can always reach out to us by message or my chart if you're noticing that your patient who might benefit from one of those procedures is waiting for too long. Our goal is, again, to see these patients quite fast, within 3 months. So if you're noticing that it's taking too long, you can just let me know. And we can definitely help providing some additional support. If you want to try some medications beforehand, you can just let us know, and we can give you some suggestions before they see us. Yeah, and the same for Parkinson's disease. You can just reach out to us if you have questions, and we can discuss how to start medications until they see us, so they're not very disabled by then. Yeah.
Nancy?
Just another logistical question. How long does the generator last? How often do you have to change it?
Yeah, so classically they last for 3 to 5 years, and you have to do a new procedure by removing this battery and putting a new one. The newer devices have rechargeable batteries. So you can actually charge with a Bluetooth device. Just put it on top of your neck, and you charge it once a week. And those last for 20 to 25 years. So it's a rechargeable battery. It's before they used to be this big, and now they are very tiny, actually. You can still see some swelling there. Most patients don't really care too much about it. And they can charge it once a week, and they're probably never going to have to change this for 25 years, maybe never in their lifetime. So, yeah, it has been improving a lot over the past few years. Yeah.
Any other questions? Thank you so much.
Yeah, of course. Thank you so much.